Uh, Good evening, everybody. Pleased to see you all here, and pleased to be able to introduce the London Presidential Lecture for the period 2021 to 2022, and to introduce you also to a good friend and colleague who I've known for, I suppose, round about 30 years now, though it's difficult to realize it's that long. The first part is the first reason why this is an original London Presidential relates to that, because it's the first time we've ever had an issue of a husband and a wife who both held this position. So that's a unique situation. The second, of course, is that the first time for many years that we've had a professor of general practice taking up this position. This position originates from the London Jewish Medical Society and from the chairmanship of the medical committee of the London Jewish Hospital. And I think we can go back almost to that period to find his predecessor in that capacity, and it's an omission that we're glad to correct. It's the first time also that we're having somebody talking who's immersed in the data management and IT aspects of medicine, which have come to the forefront over the last 10, 15 years, but particularly during the COVID-19 period. So those are all the reasons why this is a unique London Presidential Lecture. But I think that those are enough hearing from me, and you've all no doubt knew or read the CV that was put out onto the website about all Ian's incredibly diverse activities over the years. So I'm going to hand over to him to deliver his lecture.
Thank you very much, David, and thank you for asking me to be president and to give the presidential lecture. It's a great honour, and I'm deeply humbled knowing how eminent my predecessors in this post have been. So thank you very much for that. I'll start to share my screen now.
Great.
Has it come up?
It has come up.
Okay. So first I want to thank my family, my wife, Liz Lightstone, who David has already mentioned, and many of you know through her social media presence or her renal advice that she gives widely and freely. And of course, my children, Joshua and Natalie, who try to keep me grounded. I also wish to pay tribute to my father, Dr. Mervyn Goodman, and my grandfather, Dr. Abraham Goodman, who you'll learn in this lecture had a profound influence on my career. I've given this talk the above title as it's my reflections on my career as a GP, the factors that influenced me, and in turn reflecting on my influence on others. And it's interesting and ironic that as I speak, Liverpool Football Club are playing at Anfield tonight against Porto in the European Champions League, and I've recorded that match. So also looking back on 3 generations of GPs' careers may give us some perspective on where we are today and possibly how we can navigate the future. So this is the photo of the 3 generations taken shortly after my graduation. I grew up in a household steeped in medicine, Yiddishkeit and Zionism. My GP career started at an early age when I would visit my grandfather's surgery in Anfield, a short walk from both the Anfield Stadium at Liverpool Football Club and Goodison Park, home to Everton. My grandfather was essentially a single-handed GP, although for about a decade, my father supported him in his practice. So my grandfather was born in Leeds, one of 6 children, 2 of whom became GPs, which is very unusual at that time. His father was the only one of 8 siblings to leave the shtetl in Poland to come to the UK. The children of the other siblings suffered the horrors of the Holocaust in various and awful ways, although a few managed to survive. My grandfather went to Chapeltown Schule in Leeds and told me that in his father's row sat Montague Burton and Lloyd Recusen. He qualified from Leeds University at a time when there was a policy not to employ Jewish doctors in Leeds. So he travelled to Liverpool with his wife and set up a practice at Anfield, where he lived over the shop. And this is a painting of his surgery and the end of terrace house where he lived. He became a panel GP, the forerunner of the modern GP. Panel doctors, as they were called by the public, were established by the National Insurance Act of 1911 by Lloyd George, hence the term Lloyd George notes, those ubiquitous khaki GP records that GPs still receive today when patients join their practice. The National Insurance Act guaranteed employed workers and their families access to a GP from a panel of doctors. General practice was a solitary and often thankless task, and during the 1928 to 1929 flu epidemic, he told me that he visited 127 homes in a weekend, going from one back-to-back house to another, very much along roads like this in this slide, although he could offer little but solace and sympathy to these patients. Pharmacology was very rudimentary in those days. His pharmacology practical included pill rolling skills. And I remember him telling me that he would stress to patients when they came back to bring the medicine bottle he had prescribed so that he knew to give the red medicine or the green one next time. GPs would be working under very severe conditions with huge workloads. So during this period, there was much debate and discussion about the direction of travel of a health service in the UK. During his early years, leading up to the Second World War, there were several reports from the BMA recommending that everyone should have access to a GP and that GPs should be the single source of referral to a specialist. When the NHS came into being, my grandfather carried on working from his premises. The workload and working conditions didn't really improve for GPs and probably actually worsened. Because just as there is today a release of pent-up self-restraint following the waves of COVID, putting stress on primary care, after the establishment of the NHS, there was a similar behaviour. And one commentator wrote at the time, the NHS inherited the depths of a decade of sacrifice and neglect, financial poverty and disorganisation. Simultaneously, it had to meet with access to medical care no longer dependent on the means of the patient, an immense pent-up demand for treatment. An Australian GP, Dr. Collins, wrote in The Lancet in 1950 a damning report about the state of UK general practice. He saw cases where there were queues outside surgeries stretching 200 yards. His wording in his report bizarrely preempted the CQC 60 years later. Using his own subjective criteria, he reported that of the practices he visited, 44% were good, 44% were adequate, 7% inadequate, and in 5%, no assessment was made. He was clearly a man ahead of his time because, amongst other things, he advocated the establishment of GP group practices working from health centres. This report shocked the medical profession and particularly the GP community. It prompted the publication of several more reports and, more importantly, prompted the establishment of the Royal College of GPs, of which my father was a very early member. Through this period, my grandfather worked under trying conditions, on call every day and every night. In 1953, general practitioners were estimated to be making between 12 and 30 home visits each day and seeing between 15 and 50 patients in their surgeries. There was no deputising service, payments to GPs was poor, so there were constant challenges made to the government about the rate of remuneration for GPs. And this culminated in the Pilkington Report of 1960, which led to the establishment of the Doctors' Pay Review Body, which still exists today. After his spell in national service, my father, being the ardent Zionist that he was, flew out to Israel, hoping to secure a job as a doctor in the fledgling state. And despite having letters of introduction and Israel in sore need of trained doctors, the Ministry of Health proved to be impenetrable, so he flew home. It's refreshing to note that the Israeli Ministry of Health still pursues its long-standing tradition of being obstructive to this day. So he joined my grandfather in his practice, very much as the junior partner. And this was at a time when general practice was starting to encourage higher standards and encourage research. My father was a great one for working on committees and sat on local medical committees and the national BMA ones. He had the pleasure of working with one of the longest serving members of the JMA, who I think is listening in today, Dr. John Marks, who was chairman of the BMA in the 1980s. And he may want to add some more context to this at the end of my talk, because he lived through this era. I just learnt it from my father. Although general practice standards were slowly improving, with a wider acceptance of it being an attractive branch of medicine, it was still very much the poor relation, with many GPs deciding to leave the profession, sometimes even by emigrating. Between 1964 and 1966, there was another crisis of workload and low morale in general practice, leading to a showdown over pay and conditions. My father was involved in this, and although only 8 at the time, I noted tension in the air, with my father going to frequent medico-political meetings. All GPs sent to the BMA undated signed resignation letters from the government, from the NHS, and the BMA used this as a lever to negotiate with Harold Wilson's government a much more favourable contract. This was the GP Charter that heralded the Red Book and development of group practices, the building of health centres, and the start of a golden era of general practice. One practical benefit of this new contract meant that with the improved pay and conditions, my father was able to put a loft conversion in our house, where at the age of 11, I set up my very own chemistry set. In the next year, my father was given the contract to run a practice in a new housing estate in the outskirts of Liverpool for patients relocated from the slum areas of Liverpool, such as Anfield and Everton. He designed the purpose-built health centre himself. However, local authority planning for these new estates was very poor, being built to a very low budget with little heed to aspect such as social isolation, lack of public amenities and places to socialise. And you can see in this slide that the mid-rise blocks of flats had lifts that only opened on alternate floors, so that mothers with babies and prams had a real struggle, or they were simply confined to their flats. In some houses, the entry was so narrow, one couldn't get a coffin in or out without turning it vertically. And as an amusing aside, the local authority had problems of rehousing because Liverpool supporters wouldn't move into a house painted blue, and similarly, Everton supporters wouldn't relocate to a red painted house. My father wrote several papers on the impact of such poor planning on people's health. He would regularly regale me and my sisters over the dinner table about the lack of common sense within planning departments. So this is the environment in which I grew up, steeped in medical politics, the potential for general practice to improve people's lives, and the art of the possible as a GP. I was lucky to be born and grow up during a golden period of Liverpool's history. My grandfather, as well as being a GP, was for a period warden of Greenbank School. Sitting next to him as warden in the warden's box was Harry Epstein, the father of Brian. And at the end of every service, there was always a long queue of children as he handed out autographed photos of the Beatles. Although my grandfather was from a generation of Jews who were already able to get to university, my father's generation were largely able to take advantage of free education. Looking around me in Greenbank School, there were at least 6 GPs around my father's seat and several more scattered throughout. Sitting next to my father was a physician, Ronnie Finn, who perhaps should have been awarded a Nobel Prize in medicine, for it was he who did all the work to develop the rhesus anti-D treatment, saving millions of babies' lives. Of course, there was another practical reason why school attendance was so high, because this was the place where Anfield and a few Goodison season ticket holders would exchange their tickets if they were unable to get to the home match that afternoon. So this is the milieu that I grew up in. My grandfather and father were both machers in the community. Lord Cohen, after whom this association has dedicated a lecture, was a family friend. I have mentioned already my father's Zionism, and this was a very strong part of the Liverpool Jewish community. Liverpool has a very proud tradition of nurturing Zionists who made significant contributions to the establishment of the State of Israel. An early, if eccentric personality, who was a great friend of our family, was Bertram Venus, a Liverpool lawyer. He undertook the conveyancing of the purchase of land on Mount Scopus, on which the Hebrew University would be built. Bizarrely, this plot of land was owned by the widow of a non-Jewish Liverpool solicitor, Sir John Gray Hill, nephew of Rowland Hill, of postage stamp fame. In addition, Bertram Venus was a keen musician and wrote the full orchestral score of the Hatikvah, which was first performed in Liverpool in 1915 in aid of the Russo-Jewish Relief Fund. Most bizarrely of all, the score was published by the foremost publisher of Yiddish music in the UK at the time, Ralph Mazin, who happened to be my wife Liz Lightstone's grandfather. Chaim Weizmann was offered a seat on the Board of Deputies in Birkenhead, but turned it down in favour of his colleague Simon Marks, of Marks and Spencer fame. Herbert Samuel, the first High Commissioner for Palestine, whose avenue now graces the Tel Aviv Tayelet, was born in Toxteth. And finally, there was a great friend of my father, Zev Safot, who went to school with him. And when he was at Oxford, the War of Independence broke out. He abandoned his studies to go and volunteer. When he returned to resume his studies at Oxford, they refused to allow him to take his degree. However, it didn't harm his subsequent diplomatic career in Israel. He became the first Israeli ambassador to China. So I first went to a local primary school, Chilwell Primary, C of E, the building on the left. This was an interesting experience. It had large playing fields with air raid shelters at the end. As a sign of those times of a more relaxed attitude to health and safety, we were just warned not to play too close to the shelters, as there may have been unexploded bombs. Childwall is an affluent suburb of Liverpool, where many Jews moved to after the war. It was also close to where John Lennon and Paul McCartney grew up. In fact, the children from Strawberry Fields Orphanage would go to my school, Childwall Primary. When the King David Primary School moved to Childwall from its inner city site, almost all Jewish children were sent there, and then onto the King David High School, the picture on the right. I was fortunate enough to grow up with an especially talented peer group. In my class of about 30, 6 of us gained places at Uxbridge. And prior to this, only one person from the school had gained a place in its history. And after us, it wasn't unusual for pupils to gain places there. So after school, my parents sent me to the Liverpool Yeshiva, which in reality was just an advanced cheder, where I studied Gemara for a few years. This yeshiva was at the junction of Penny Lane, and I would regularly have my hair cut at the barber with his photographs on the wall. In the 6th form, I changed schools to the Blue Coat, but continued having my hair cut there, as the school was also at the end of Penny Lane. When the Yom Kippur War broke out, I was 15, but like Leonard Cohen, was determined to give my support. So with a group of friends from school, ran a raffle to raise money for the war effort. This wasn't a small-scale project, but one where we cajoled major gifts such as a TV and other significant prizes from local businesses. We then went door to door selling raffle tickets in aid of the war effort. I think we raised over £600, which was no mean feat in those days. We would knock on every door in our neighbourhood, whether they had mezuzahs or not. The result was always supportive. How times have changed. This was the first time I realised that my actions could have important positive consequences. So at medical school, I got involved in the medical societies and helped run the medical school magazines, as well as student balls, both at Cambridge and at St George's. I was on the last firm in the old Hyde Park Corner site, and every day I would cycle from Tooting to Hyde Park Corner. In those days, there were no traffic lights at Hyde Park Corner, so cycling around it was a great sport. I also set up Pan London Medical School student magazine for the 12 medical schools at the time, and amongst the other founding students in the group that set it up was one Simon Wesley. It was at medical school where I met my wife, Liz Lightstone, who, as you're probably aware, predates me as president of the JMA by a few years. She, with my tolerant, long-suffering children, have been a constant support in my career choices. However, despite coming from a long line of doctors, our mealtime conversation clearly put both of them off, following in the Goodman tradition of medicine. So 4th generation of doctors is not to be. We now have 2 lawyers in the family. Undoubtedly, the influence of my grandfather and father played a significant part in my choice to become a GP. It was also made by the fact that I wanted to be more of a generalist and wanted the experience of following patients through their lives. So after the GP training at Northwick Park, I was accepted as a partner in a group practice in Northwood and have been there for over 35 years. When I joined it, the partnership was made of just the GP partners, no nurses, practice manager, or other ancillary clinical staff, although we did have district nurses and health visitors who would come and discuss patients with us. In my arrogance at the interview for the partnership, I warned the partners if they took me on, I would expect to make significant changes and develop the practice. And despite this, they still took me on. Within a year, the practice had joined the Royal College GPs Research Network, acquired a computer and a practice nurse, and shortly after I became a GP trainer and trained on the Northwick Park Hospital Scheme for 27 years with Oliver Samuel, who I believe is also watching this lecture. The mid-80s to the turn of the century was a period of rapid transformation in the world of general practice. Computerization was starting to take hold, and one of the first things I did on joining the practice was get a computer. In those days, there was a tendency to name computers after fruit, and our computer was an apricot. We used it to enter data of every single consultation, not the history though, but the presumed condition. And we were taking part in the Royal College of GPs research network, and so coded these entries in a particular way. At the time, we used the RCGP codes, of which there were only 6,000, and we had to put a suffix of F, N or O after the code we'd used on whether it was a first episode, a new episode of a pre-existing condition, or a routine follow-up. And this enabled us to separate incidence from prevalence easily. I suggested to the research team at the college that we should link certain codes to a particular period, that they would remain on the active condition list on the computer. For instance, an upper respiratory tract infection would only stay on for 28 days, but a disease like asthma would be permanent. I took on the arduous task of going through all the codes and links for the Royal College of GPs, and I'm thankful that James Reed hadn't sold his codes to the Department of Health at that time, as his coding system had many thousands of codes. And this system is now used and embedded in all GP computer systems. In 1988, I was asked by the Chief Executive of Hillingdon Family Practitioner Services to become its first GP computer facilitator. In this role, I persuaded all GPs in Hillingdon to acquire a computer. And this was at a time when they had to pay for the computers themselves, but got partially reimbursed by the NHS. There were a couple of schemes that were set up by commercial companies who enticed practices to acquire systems for free in return for their data. But these schemes turned out to be little more than Ponzi schemes, and some practices ended up out of pocket. Having had some initial success in Hillingdon, I then partnered with another GP from Ealing, and together we initiated a scheme which enabled the outer Northwest London GPs to acquire EMIS computers at a favourable rate. Then this led me to being asked by the NHS to be the GP representative on the GP Computer Standard Setting Group, which produced the first set of standards for GP computer systems, called RFA 99, Requirements for Accreditation 99, because it was published in 1999. Once these standards had been set up, it allowed the NHS to institute a system of full reimbursement for approved GP systems. This was a period of achievements in primary care. Not only were GPs computerising, but they were expanding their practice teams to take on additional staff, both clinical and non-clinical. General practice was a favourite choice of career. Whilst all these changes were going on, the Conservative government was introducing yet another GP contract. The changes proposed that GPs should receive more of their pay from capitation, health promotion would become an explicit part of the contract, children's immunisation and cervical cytology would be paid by hitting certain targets, and practices in deprived areas will be assisted by extra payments based on Brian Jarman's criteria. This was the start of a move to effective health prevention as part of the GP's role. As usual, many GPs didn't like these changes, and the GP negotiators weren't happy either. The previous 1966 contract was felt to be slightly out of date and needing to be tweaked. However, unlike in 1966, when the profession's negotiators held a very strong hand because general practice had been deteriorating and was widely regarded as an unfulfilling career, morale was so low that many GPs were leaving the practice. However, in 1990, GPs were well motivated, worked in premises provided largely at public expense, had no difficulty in recruiting colleagues, and public attitudes to organised industrial action had changed. GPs faced a strong government determined on consumer-oriented reform, and the negotiators had little to negotiate with. So the Conservative government in 1990 brought in a new GP contract, and this established fund holding for GPs, as well as the other innovations already mentioned. This contract turned out to produce some welcome changes. GPs appointed many more nurses, increased their minor surgery, organised their practices better, installed more computers, and achieved higher rates of immunisation and cervical cancer screening. The radical left-wing GP, Julian Tudor Hart, who coined the term the inverse care law, conceded that although implemented by a Conservative government, the new contract had been an unexpected success. Our practice was one of many which took advantage of these reforms, and due to fund holding, were able to put any unspent budget into the new surgery, which we built in 2006. Although fund holding wasn't universally accepted and the BMA opposed it, many practices, including our own, found it beneficial on many levels. Firstly, using our budget, we were able to influence hospitals to become more efficient. An example of this is of our two local hospitals, Northwick Park and Hillingdon. Northwick Park offered much more day case surgery than Hillingdon. In those days, day case surgery was still fairly innovative. We therefore referred most of our patients to Northwick Park, which reduced patient waits and reduced our costs. Hillingdon Hospital, realising that their stream of elective surgical patients was dropping, soon switched to offering more day case surgery, making the running of the hospital much more efficient. By 1997, 59% of practices were fund holding, but in rural areas such as Derbyshire, it was as high as 80%, and in inner city areas such as Camden, as low as 4%. However, by the turn of the century, storm clouds of GP conditions were once again gathering. GPs were getting worried about the stresses that out-of-hours work was adding to their life. So in 2004, after intense negotiations with the Labour government, a new GP contract was introduced, which significantly, but only temporarily, increased GP income. It also abolished the contractual requirement for GPs to do home visits after 6:30, nor open on Saturdays. Unfortunately, the GP negotiators were a bit too public in their achievements, and over the next 16 years, successive governments have slowly altered the contract to make general practice more onerous and burdened with tedious bureaucracy. A few years earlier, in 1996, a few GPs, mainly from Harrow, Hillingdon and Brent, had set up a GP cooperative visiting service called Harmony, which had greatly reduced the stress of out-of-hours GP services for their GPs. Every GP agreed to do approximately one session a month, and in return, they wouldn't have to do their own practice out of hours. I was one of the founding directors of Harmony and helped introduce digital innovations into the service. I'm very proud of one particular innovation around passing messages from Harmony into GP computers, as this gave GPs for the first time the ability to see a comprehensive view of the out-of-hours consultation and then collapse it down. I was almost as proud of the acronym I came up with, EXOCET, Exchange of Clinical Information Electronically. We doctors do love a good acronym. Harmony brought in many innovations for the running of out-of-hours services, including the transfer of electronic consultations, the use of evidence-based clinical algorithms for triaging, and out-of-hours end-of-life management pathways. But probably the most important aspect was that we showed that a clinically led, well-managed GP service could get enthusiastic buy-in from a wide range of GPs, and this could be a successful venture navigating the vicissitudes of the NHS bureaucracy. Ironically, the introduction of the new GP contract meant that GP co-ops had to become more commercial, and many went to the wall. Harmony rose to this challenge and became the largest out-of-hours provider in the UK before being bought out by Care UK in 2012. At its height, we were looking after most of the English population south of Birmingham. Every GP from outer northwest London boroughs who had bought into the co-op originally and had contributed to its success had a share in the sale proceeds. With the advent of clinical commissioning groups in 2012, I was elected chair of Hillingdon CCG. GPs became more involved in shaping and commissioning local services, and CCGs were much better at involving patients in the design of services. Despite CCGs giving GPs a much greater say in how services were to be commissioned, the life of the average GP became more burdensome. Computers, instead of making life easier for GPs, have seemed to make life harder, as politicians have realised how much more scrutiny they can have over a GP's work and impose increasing numbers of targets to achieve. In 2015, the 8 North West London CCGs initiated a plan to establish a pan-North West London database and digital record for all its residents. This was the whole system's integrated care database. I was the senior clinical responsible officer for this project. This database took activity data from GP surgeries, acute trusts, mental health and community trusts, as well as adult social services. It was the most comprehensive database in the NHS and possibly Europe at the time. Initially, we used it to identify health needs in selected health areas, like asthma. But in reality, the WSIC is more than a database. It's a comprehensive patient record where GPs can access their own patient data and view all their health-related activity, irrespective of where it took place in North West London. As you can see, the coverage we have is impressive, with over 2.5 million records. And the next few slides will give you an inkling into how we can use WSIC, and really it's still in its early stages. So simply, we can use it to do 3 basic things from a clinical perspective. We can select patients with certain conditions who we want to drill down into their care. And we can use things like patient radars that you'll see a bit later. Or we can look at a whole group of patients with long-term conditions. So we have what we call asthma radars or diabetes radars or COPD radars. And then we can look at the care of a total area of patients. Or we can look at the population health, where the CCG or PCNs can then look at an anonymized group of patients with a condition like asthma, and then look at how well they're being looked after, or whether we're hitting all the necessary treatment types that we should be performing. As an example, this is a slide from a diabetes radar, and you can see that we slice and dice the data. So that on the left-hand side graph, that's a graph of actual non-diabetic hypoglycemic patients' incidence, prevalence rather, with expected. And on the right side, we've got the prevalence of actual diabetes with the expected rate of diabetes. And as a clinician and as a GP, what I can then do is drill down, and I can get a list of patients, as you can see on the left-hand side, and then look at various aspects of their care. So you can see here, we look at whether they've got care plans, and if the care plans are up to date, whether they're mental health users, or whether they have access to social care. And I can then drill down into each individual record like this. This is a rather noisy record, but what it shows us in the first half, the upper half, it tells us the conditions that patient is suffering from. In the lower half, you can see these horizontal lines, which we call swim lines, and they're lines over a period of time. And going down, it shows their contact with healthcare providers. So every vertical bar you see along those lines is where that patient has had a contact with a healthcare or social provider. And as you can see, this dummy patient has had quite a few contacts, and you can drill down even further to see exactly what happened, or you can press on some of the icons at the bottom to see what medication they're on or what investigations they've had. So this is a really comprehensive record that you can't find anywhere else in the NHS at the moment. The way we used it in Hillingdon, as an example, was we have a team of what we call our care connection team, which is made up of a community matron, a social prescriber, and a GP, and they meet every practice on a weekly basis. And if you can see at the graph on the right-hand side, the orange line is the activity of the care connection team. And you can see that as they got more involved with the patients, the number of these frail patients who we've identified turning up to A&E dropped considerably. And similarly, the number of these patients who were admitted as emergencies also dropped. But of course, having over 2.5 million records is a rich source of data. So we're working with Imperial College health partners to do a wide range of research. The Imperial College health partners only have access to anonymized records and not to identifiable records. And in COVID, you can see how this really came into its own, because we were able to download data from GPs and from hospitals on a daily or even more frequent basis to look at the activity and the incidence and the effects of COVID on our population. And we use this data to see what the current state of COVID was in Northwest London, and we use it to model our bed usage and to open up capacity and manage particularly the second stage, the second wave of pandemic, the beta wave, which you can see in the middle graph at the top on the admissions. Now, what you can see in this radar, actually it's more of a snapshot, is you can slice and dice the data by CCG or by primary care network or by GP practice or by vaccination status. And the bottom half of this data sheet, it shows the demographics of these patients, their ethnicity, their age, sex breakdown, the borough they live in, and their deprivation status. So, but more recently, I've started working with our local university, Brunel. They've set up a school for physician associates, as well as physiotherapists, and this year nurses. Next year, they open up their medical school. Initially, this will be open only to non-UK residents, as Health Education England haven't the funds to support UK residents. At the beginning of 2021, I was appointed Professor of Primary Care Strategy in the new Brunel Medical School and involved in developing the primary care training and developing future initiatives. The medical school will be teaching via an innovative process called team-based learning, and this is used widely in New Zealand and Singapore instead of lectures. It will also be developing multidisciplinary learning modules. So this brings us to the present day and beyond. The whole of the NHS is in crisis, but general practice and A&E departments are probably in the most critical position. As I stated earlier, the huge increase in bureaucracy, the obsession with process rather than outcomes, the need to hit arbitrary targets, and the shrinking workforce are the major reasons for the current crisis in general practice. Paradoxically, the use of digital technology has also increased GPs' workload, and this is ironic, as elsewhere, digital technology has been used to decrease workload and often reduce workforce. What digital technology appears to have done in general practice is uncover significant areas of unmet need, which formerly were known about, but not quantifiable. It's also made access to GPs easier and quicker, with e-consult forms for appointments, often for trivial issues, being sent into practices 24/7. And of course, post-COVID matters have been made worse by continual sniping by media and politicians. So general practice is at a crossroads. Increasing numbers of new GPs are opting for a portfolio career, often allocating only 4 or 5 sessions a week in practice, and do not want the responsibility of becoming an equity partner. I find this intriguing, really, because as one of the advantages of being a GP principal is you have control over your ability to have a portfolio career at the same time as being a partner. At the moment, taking on the responsibilities of running a practice does not appear to be attractive to many. Will general practice, as some pessimists think, be taken over by private organisations to sweat the assets and then abandon it, or will it rise out of its current ashes? The role of doctors in general, and GPs in particular, will alter drastically over the next decade, with the technological advances being made. We are already performing virtual consultations and remote monitoring of patients and setting up virtual remotely monitored wards. The full impact of artificial intelligence is yet to be realised in medicine, but is making rapid advancements. Genomics is starting to become mainstream, and for GPs, the growth of health apps on phones, coupled with cloud computing, will bring different challenges, whilst miniaturization will bring more sophisticated diagnostics into general practice. Personally, I have a fairly optimistic view. As you've heard, the history of general practice paying conditions is one of cyclical hardships followed by political concessions. I don't think there are many assets to be stripped in general practice, although the value of GP data has not been fully realised yet. We may be at a state of crisis similar to 1966, and certainly in terms of GP workforce and morale, this may be true, with GP numbers falling year on year, no matter how the NHS tries to manipulate the statistics. The BMA is talking about balancing GPs regarding taking industrial action. Jeremy Hunt has just announced he will lead an inquiry into the state of general practice. I hope that what my talk has highlighted is that over time, there are many medical advances improving the management of many illnesses. However, the conditions we work in suffer, and probably always will, from cyclical challenges, as the demand on access to healthcare will always outstrip the ability for the NHS to provide it. Opportunities for GPs will always be available, and this is one of the aspects which makes general practice so interesting. I went into general practice with the advantage of having 2 GPs from 2 different generations as my role models. I always planned to take on roles in addition to seeing patients. In many ways, I'm surprised at how well this has turned out. Thank you.
Thank you very much, and with a perfect image to end off. I'm sure that there are going to be questions that other people are going to raise, but I'm sure that this is also very thought-provoking, and I'm sure that there are going to be questions we're going to raise over time. One that I wanted to immediately ask you is that you're referring to the Brunel University and to IT skills and to the question of doing online patients as well as patients in face to face. What's Brunel going to do about those kinds of issues?
Well, Brunel will, like all the other medical schools, be trying to keep patients in campus as much as possible. And in fact, the medical school will be taking overseas students, so they'll be living on campus. And in fact, Brunel has one of the largest ranges of student accommodation, with I think over 4,500 student rooms for them to stay in. So we're very much planning that they're going to be on campus and actually placed in general practice. And one of my major roles is to place them in general practice from the beginning of their medical student career in their first term. When we're hoping we won't have to do much, if any, virtual teaching.
Before I come to the question that's just come up, just the question is that who's training the teachers to put them into general practice early on? Is there an education program for teaching?
There's a wide education program. The curriculum is being designed from the bottom up within Brunel. It's not being bought off the shelf. And so people like Pete Abrams, who's also on the call here doing the anatomy course, the GPs will be going through a quality assurance process, and they'll be trained and they'll be assured. And the GMC watches this very carefully.
Right. The question that's raised on the Q&A is the question about, kind of, as you do preventive medicine, decrease heart disease, decrease diabetes, kind of how does that shift the emphasis in general practice, and how's that impacted on the evolution of general practice?
Well, it's interesting, because when I was training 40 years ago, I went into general practice. The only thing we did in general practice in terms of preventive medicine was blood pressure checking. We didn't do any cholesterol. We didn't do any of the other preventative stuff, heart disease management. We did a lot of acute medicine, and in fact, I remember seeing patients at home who'd had acute myocardial infarctions and giving IV infusions of frusemide rather than admit them. We didn't do much diabetic care, but over the years, more and more of these conditions have moved out into general practice as the skills of GPs has increased and training has changed. This is going to change again, because I think genomics is going to have a huge impact on how we treat our patients in the community. And there's a whole ethical issue around genomics around that. And then again, diagnostics, things like ultrasound and scans, the use of apps on mobile phones. You can already get apps that will convert your mobile phone into an ECG or even an ultrasound. Patients will bring those into the surgery and ask GPs advice. So I think the role of GPs will become more complex but more interesting.
Right. I mean, it's one of the questions that Claire Walford has raised is today's report, which also notes about Medscape. In the United States, people are using their mobile phones to video their GP consultations. Do you think this is going to start to happen here? And do you think we're going to start to have, kind of being sued on the basis of the video?
It's interesting, because what happens in the States often comes over here in about 10 or 15 years' time. So yeah, it's possible, and also the remote video consultations that we do could easily be recorded in time, and it may be just one of those things we have to get used to. We've got used to the fact that patients can now access all their medical records, whereas it used to be that they weren't allowed to at all, under pain of death, literally, not being allowed access to their records. So this is just another advancement in patient power, if you like. And I suspect it will happen here in 10 or 15 years' time. It
reminds one actually that videoing of all sorts of consultations and all sorts of and all sorts of in examinations is actually quite widely accepted today, isn't it, by patients?
Yeah.
So there's the patient acceptance of that kind of thing is very straightforward.
And patients are very commonly now shopping around more. There's things like GP at hand, push doctor. So it's becoming more of a consumerist process to get healthcare advice, and they will go to Dr. Google invariably before they come to the GP with their own ideas. And in some respects, being a GP is a bit like being a second-hand car salesman. A patient will come in with their own idea of what's wrong with them or what they need to be treated. And then you've got to persuade them, in fact, that what they really have is something different and the treatment may be different.
Yeah, right. Okay. I think that what you've given us is a historical as well as a general practice and IT talk. And you've given us a great deal of food for thought. We hope that you're going to enjoy your role for the coming year. I have very fond memories of course, of your father, because he was one of the people who persuaded me to get involved in the BMA, and I'm not quite sure whether everybody agrees that I should be grateful for that, but he certainly did. He also, of course, used to encourage me to attend Limud, which was a favorite of his.
Yes.
And he would have been extremely proud and happy to have been here tonight. Thank you very much. And we look forward to the coming time. And as you might have noticed from your wife's experience, one of the changes that we've evolved from the London Jewish Medical Society is that we retain connection to the presidents, London presidents, in the long term. So we look forward to the coming year and to the long term. Thank you very much.
Thank you. I look forward to it too.